Hello everyone, I am Dr. Abhishek Sachdeva, intervention cardiologist, assistant professor in Motilal Nehru Medical College, Prayagraj, and director of Asha Healthcare and Research Center, a non-invasive cardiology center in Prayagraj. So today we will be talking about latest update in hypertension. As you all know, as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular diseases, which affects 45% people in the 40 to 69 age group. So, raised blood pressure is among the most important risk factors for cardiovascular diseases. Moreover, it remains popularly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. As per the data which is published in the journal Lancet in 2021, nearly half of the people, or 51% of the men and 41% of the women with hypertension, were aware of the condition. Additionally, over 62% of men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. The American Cardiology Society has released a scientific statement in the year 2021 offering new guidelines for management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults, that is, no ASCVD or less than 10% 10-year CVD risk with stage 1 hypertension, which we say that the blood pressure is 130 to 139 systolic and 80 to 89 millimeters of mercury diastolic. The management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacologic therapy. Even in this COVID era, it has been proven in a recent study that was published in the Journal of American College of Cardiology that metoprolol can reduce lung inflammation and improve respiratory function in patients with COVID-19 induced acute respiratory distress syndrome. Lowering systolic blood pressure targets down to 110 to less than 130 millimeters of mercury range substantially reduce CV adverse events in the STEP randomized trial, affirming the data which we have got from the SPRINT trial, which was for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive treatment target trimmed 26% of the composite CV risk. Finding from now a secondary major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold of 130 to 150 millimeters of mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP measurements, but also on out of office measurements such as home based blood pressure monitoring or ambulatory blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risk of mortality and a composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 10 millimeters of mercury increment of BP measured at night, the risk of mortality increases. The risk of mortality increases by 23% and the risk of cardiovascular events increases by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and blood pressure control. Therefore, the 2018 European guidelines recommended, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitors or ARBs with calcium channel blockers or diuretics. Since early July 2018, products containing valsartan have been called worldwide, as we all know. The reason is the detection of a known carcinogen, namely NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO, International Agency for Research or Cancer, to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from the Seizing Hawaii, that is the manufacturing site where the highest level were found, every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recalls accompanied by a significant increase in the rate of emergency department visits by 6%. The Hagia study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoint. The Hygia chronotherapy trial tested whether nighttime therapy, in comparison to usual upon awakening hypertension therapy, experts a favorable CV risk reduction. The largest study included a total of 19,000 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP of differed during sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. So thank you. Today we have discussed about the latest updates about hypertension, and I hope we as doctors and our patients will benefit from these guideline directed medical management. Namaskar.